These are staphylococci. They exist in a symbiotic relationship in the skin flora and mucous membranes of most people. Staphylococci and all the other microorganisms that we normally live with can be deadly for our patients. As a patient advocate, one of the most important responsibilities for the perioperative nurse is to monitor and maintain a surgical setting free of microorganisms that may cause infection. The goal is to enhance primary surgical healing, prevent infection, and shorten the patient's recovery time. Adhering to the principles and practice of aseptic technique will help the perioperative nurse to meet that goal. Aseptic principles guide the perioperative team as they create and maintain a sterile field for performing surgery. These techniques isolate the surgical site, separate it from the surrounding unsterile environment, and prevent contamination from reaching the open incision. For purposes of demonstration, AORN's position of a first assistant not functioning concurrently as a scrub person is not visually demonstrated in this video. The basis of today's aseptic technique began in the late 1800s when the healthcare community became aware of clinical hygiene and asepsis. Surgical site infections were so common that the doctors considered them a normal outcome of surgery. Florence Nightingale was one of the early pioneers of aseptic principles. She saw a correlation between cleanliness and patient recovery. With this information, she advocated clean sheets, clean gowns, and decent surroundings for patients. She expanded the role of the nurse to include protecting patients from infection. By the late 1800s, Louis Pasteur was killing germs with both heat and cleaning to reduce their number. Joseph Lister was using carbolic soaks and sprays to reduce microorganisms. Use of these antiseptic methods resulted in a drop of surgical mortality from 45% to 15%. Microorganisms are in the air and on both animate and inanimate objects. They are microorganisms that may cause potentially fatal infections if not kept away from the patient. Understanding how organisms invade tissue will help the perioperative team form a surgical conscience to maintain aseptic technique. Bacteria are either aerobic or anaerobic organisms. Aerobic bacteria sustain their life with oxygen. Anaerobic bacteria exist without oxygen. Some pathogens are primary invaders. Others are opportunists that secondarily invade an already infected host. Non-bacterial microorganisms may also cause infections. They consist of a broad range of fungi, protozoa, and viruses. Classifying these organisms helps healthcare personnel control contamination and treat infected patients. To propagate, microorganisms need moisture, food, proper temperature, and then time to reproduce. During transfer from one place to another, they become dormant for about 5 hours. Then, each organism begins dividing itself every 20 minutes. A spore is the resting stage of some rod-shaped bacilli. They have a protective, thick shell that is resistant to destruction. They remain in this state until conditions are suitable for growth. In this stage, spore-bearing bacteria succumb to sterilization and disinfection. People are the major source of contamination in our environment. In the healthcare setting, the intense interaction of staff and patients contribute to the prevalence of microorganisms. Microorganisms journey into the surgical areas primarily on people. Environmental controls such as requiring surgical attire and head coverings in restricted areas help to contain organisms. The sources of contamination are skin, hair, nasopharynx, fomites, air, human error, and cross-infection. Skin from patients, visitors and the healthcare team creates a significant contamination hazard. Every minute, an average person's skin sheds 4,000 to 10,000 viable unseen particles. On all people, the major areas of microbial population are the head, neck, axilla, hands, groin, perineum, legs, and feet. Completely covering all the skin is the most effective way to contain microbial shedding. Hair follicles and sebaceous and sweat glands contain abundant resident flora. Hair is a gross contaminant that attracts and sheds large populations of microbes. The population size is in direct relation to hair length and cleanliness. Talking, coughing, or sneezing forcibly expels droplets of organisms that settle on surfaces, creating bacteria-laden dust and lint. A fomite is an inanimate object or substance capable of harboring and transmitting pathogens. In the operating room, contaminated particles live on furniture, walls, floors, equipment, supplies, and fabrics. Ambient air transports between 80% and 90% of the microbial contamination found in an open surgical site. Particle count in the operating room can rise from just thousands of submicron particles per cubic foot to more than 1 million. Every movement by the surgical team increases the potential for contaminated air to flow over the open incision. Direct person-to-person contact, exogenous contamination, spreads more infection than any other means. A break in aseptic technique exposes the patient to a preventable risk. Readily admitting and correcting errors in aseptic technique is everyone's responsibility. Cross-infection is the transmission of microorganisms from patient to patient and from inanimate objects to patient and vice versa. A break in aseptic technique may result in cross-contamination. All patients are considered to be infected and treated as such, using the same precautions. Following standard and transmission-based precautions, including hand washing, is the important technique to prevent cross-contamination. Environmental sanitation helps to control and reduce exogenous contamination. Disinfectants used on fomites destroy most forms of pathogenic organisms except bacterial spores. The surgical suite should be cleaned according to the AORN recommended practices for environmental cleaning in the surgical practice setting. Saturated steam under pressure generating 270 degrees at 30 psi for 3 to 10 minutes maximizes the killing of pathogenic and non-pathogenic organisms, including spores. Detailed information on sterilization can be found in the AORN recommended practices for sterilization in the practice setting. Good traffic control practices protect patients, personnel, and materials from cross-contamination. The recommended practice is a 3-zone designation determined by the physical activities in each area. Unrestricted zones are those outside of the surgical suites. In these areas, personnel may wear street clothes and move about freely. Semi-restricted zones are the corridors that lead to surgical suites and the processing and storage areas. All personnel must wear appropriate surgical attire and hair coverings. Patients must wear gowns and head covering. Only authorized personnel and patients may go into the semi-restricted areas. Restricted zones include the operating rooms, clean core, and scrub sink areas. All personnel must wear surgical attire, hair coverings, and masks if there are open sterile supplies or scrubbed persons present. Aseptic technique is the practice of preventing normal body flora from contaminating the surgical site by restricting microorganisms from the environment, equipment, and supplies. Surgical procedures must protect the patient by keeping the surgical site within a sterile field that is free of all living bacteria, including those initially present on the patient's skin. The skin is the body's first line of defense. The first step toward preventing surgical site infection is to clean or prep the patient's skin using an antimicrobial agent. The objective is to remove soil and transient organisms, reduce the resident microbial count to subpathogenic levels, and inhibit rapid rebound growth of microorganisms. Part of the skin preparation may include hair removal, which should take place as close as possible to the operation time. Sterile sheets and towels form barriers to bacteria and create the sterile field. In this zone of asepsis, the drapes isolate and expose the incision site. All instruments, sutures, and fluids entering the sterile field must be free of all organisms, including spores. Only scrubbed persons may access the sterile field. All members of the surgical team must wash their hands. The team members who will access the sterile field must scrub their hands and arms to reduce their bacterial count. In addition, they wear hats, surgical masks, sterile gowns, and sterile gloves. Everyone who enters the semi-restricted and restricted surgical areas dons surgical attire to contain skin shedding. Perioperative nurses help to prevent patient infection by using microbiologic and epidemiologic concepts for asepsis. The AORN recommended practices are based on these principles of aseptic technique. Recommended Practice 1. Scrubbed persons function within a sterile field. The surgical team consists of two groups. One group works directly at the surgical field. They are the sterile group or scrubbed persons. They can only touch sterile items. Scrubbed persons must wear sterile gowns and gloves. The other group works outside the sterile field. They are the unsterile group and touch only unsterile items. Sterile team members perform the surgical hand scrub before entering the operating room. The hand scrub removes transient and resident microorganisms from their hands and arms. The scrubbed members then don sterile gowns and gloves that they must be wearing before they can access the sterile field or sterile equipment. This practice maintains the principle that sterile can only touch sterile. The gown is sterile in front from 2 inches below the neck to the table level of the sterile field. The sleeves are sterile from 2 inches above the elbow to the stockinette cuff. Since the cuff is no longer sterile after donning the gown, the sterile gloves must cover them at all times. The unsterile areas of the gown are areas that the scrubbed person cannot see. The gown is considered unsterile from 2 inches below the neckline up. The shoulder areas, areas under the arms, and the back. The back of a wraparound gown is also unsterile. The scrubbed person keeps their hands within the sterile boundary of the gown to maintain glove sterility. Crossing the arms and positioning the hands in the non-sterile axillary region, or putting hands or any sterile item below the sterile field, is a break in technique. Recommended Practice 2. Sterile drapes should be used to establish a sterile field. The surgical team places a barrier or sterile drape over furniture within the sterile field to prevent contamination of equipment and personnel. The patient, once covered with a sterile drape, becomes the center of the sterile field. When draping the patient, the scrubbed person drapes the incisional area first and then the periphery. They keep the sterile drapes above their waist level until properly positioned. Any point below the sterile level is unsterile and off limits to the scrubbed person. To cover surfaces properly, the scrubbed person drapes from sterile area to unsterile area by draping nearest first. Unscrubbed persons should never reach across a sterile drape. Anything that permeates the sterile field, including moisture, called strike-through, contaminates it. Covering or replacing the item or area in question is the appropriate corrective action. Recommended Practice 3. All items used within a sterile field should be sterile. To prevent contamination, the surgical team should never mix sterile items with unsterile ones. To ensure that an article is sterile, anyone who opens and dispenses an item is accountable for its sterile integrity. The shelf life of a packaged item is event-related. Factors considered to affect sterility include packaging materials, number of times handled, number of personnel handling, open or closed shelves, condition of storage areas, use of dust covers, sterilization date on package, package integrity, and method of sealing. Recommended practice 4. All items introduced onto a sterile field should be opened, dispensed, and transferred by methods that maintain sterility and integrity. Prior to dispensing sterile supplies, check the outer package for tears or holes and consider it contaminated if they exist. Confirm that an item's sterility has not been compromised by handling. Inspect the indicators on the outside of the package to make sure of the proper sterilization process. If indicated, verify manufacturer's label for sterility, outdate, and do not use the item if sterility is in doubt. For wrapped supplies, the unscrubbed person should open the wrapper flap farthest from them first and the nearest flap last. This prevents passing an unsterile arm over a sterile item. After opening a sterile container or wrapper, the surgical team can consider the edges of the package contaminated. The person pouring a sterile solution lifts the lid straight off and must pour slowly to avoid splashback. After pouring, any solution remaining in the container should be considered unsterile and discarded. Recommended practice 5. A sterile field should be maintained and monitored constantly. The scrubbed person should prepare the sterile field as close as possible to the time of surgery. This minimizes the potential for contamination that increases with time. To ensure the integrity of the sterile field, the scrubbed person will keep it in direct view at all times and not turn their back to the sterile field. Recommended practice 6. All personnel moving within or around a sterile field should do so in a manner to maintain the integrity of the sterile field. If scrubbed persons need to change positions, they may move either face-to-face, sterile side to sterile side, or back-to-back, unsterile to unsterile. Since air currents are a source of contamination, movement within or around the sterile field should be minimal. Unscrubbed persons may not walk between two sterile fields or setups. A proper air filtration system effectively reduces the number of airborne organisms by removing dust and aerosol particles. The surgical staff must keep the operating room doors closed during a procedure to minimize mixing air from inside the operating room with air in the corridor. A surgical conscience builds on the principles of asepsis. It is an act of mental discipline. It requires inspection and regulation of one's own practice. It calls for particular attention to deviations from acceptable and safe practices. It demands the recognition and immediate action to correct improper practices by any member of the surgical team, including oneself. To cultivate the inner voice of surgical conscience, the perioperative team should ask themselves these questions before each procedure. Is this the best setup for the procedure? Do I have everything that is essential under existing circumstances? Do I know what is required of me to be of the greatest assistance to the rest of the team? Have I done all that I can do to provide a safe and healing setting for my patient? What can I do for the patient that I would want the surgical team to do for me? When a knowledgeable operating room team adheres to the principles of aseptic technique, it is more likely that the patient will be infection-free.